Okay, thank you. Thank you very much, Diane, and good morning, everybody. I hope you've enjoyed the session so far this morning as much as I did. They were really thought-provoking, and I think have certainly made me think about the work that Ashleigh and I are doing and how we can maybe contribute to some of the debates around inequality and definitely around personalised care, because that's what our presentation is about. So as Diane said, I'm Suzanne Crozier. I'm currently at Northumbria University as Principal Lecturer, lead midwifery education, although I'm shortly to be joining Edinburgh Napier as an Associate Professor. So if you wanted to contact me afterwards, possibly that Ashleigh might be a good person to contact, and I'm going to I'm going to invite Ashleigh to introduce herself now as well. Ashleigh.
Thanks, Suzanne. Hi, everyone. I'm Ashleigh Blackwood. As Suzanne says, I work at Northumbria University. I feel like a bit of an interloper today because I'm not actually a qualified midwife. I work in the literature division of the Humanities department. I work on a project called Writing Doctors, so that has me specialising in 18th century literature and medicine. And contrary to what the title would suggest, my expertise is actually in rediscovering and establishing a history and humanities for midwifery, which is what brought Suzanne and I together.
It did indeed. Thank you. And so the title of our presentation this morning is an interdisciplinary approach to personalised care using historical midwifery text to understand contemporary challenges. And for me, in particular, as a midwifery educationalist, where I've spent a lot of time thinking about interdisciplinary work, and that's often meant working with, and it's been referred to this morning, working with obstetricians, with social workers, with neonatologists. It's been a real benefit for me to work with a completely different discipline in the humanities. And I know that Ashleigh's colleagues in the humanities department were particularly excited when I turned up at one of their seminars and she'd managed to find a real midwife. They were very excited about that. But moving on, I think it's really important to just identify how important those different disciplines can be in shedding light on some of these real tricky problems that we were talking about earlier. How can we actually make action happen and make things move forward? So I hope the slide has moved on, and it hasn't. Sorry, just let me try on this one. There we are, as the slides moved on. So very quickly, just a little bit about Northumbria University. We're up there in Newcastle upon Tyne, right bang in the middle of Newcastle, one of the great student city. And just to say that Ashleigh and I met when we were both working in teaching and learning in the centre of the university. Ashleigh representing the student union. I was there as a director of teaching and learning. And I was planning a new workshop for our third year students around professionalism and understanding personalised care and sort of where the future of midwifery was going. And I thought it would be really helpful for them to have some reflection on the history of midwifery. And then when I was talking to Ashleigh, it became apparent that actually personalised care was quite a key theme that we could take from the past into the present and maybe forward into the future. So that's sort of where we came from with this idea. And we did run that workshop with our third year students, and it went down really well. They found it really, really interesting. And that led to the small project that we've got with some internal money to sort of explore these ideas and these concepts further. So what I wanted to talk a little bit more before I hand you over to Ashleigh and to the historical text was just to recap. I guess for many of you will be very familiar with the idea of personalised care. In fact, this morning we've had reference made to women-centred care and to individualised care as well. And I think there's lots of different terms that people use, and that can be one of the challenges, looking for a definition of what personalised care is. The Personalised Care Institute there do provide you with a definition, which is about working in partnership, helping people to make informed decisions and choices about their health and well-being, alongside clinical information. And better birth's obviously really important for midwifery, Better Births talks about personalised care being around the women making detailed care plans after they've had full discussion, shared decision making and choice over place of birth, and many of the other decisions that need to be made. So what we can see then is personalised care is about being involved in decision making, it's about enabling choice, and it's also about feeling listened to. And it's important as well to pick up on the woman's voice as part of this discussion, because the woman's voice is presented to us in language, in words. And I think I'm very mindful of what Gloria was saying earlier about actually some women don't have a voice simply because they don't speak the same language as the people who are listening to them. And I think we really need to be cognizant of that. The Maternity Services Survey 2018, I know there's been a more recent one, but sorry, my slide is slightly out of date. I think women wanting to know really value being asked how they feel emotionally during antenatal care. Feeling listened to by midwives is really important, being spoken to in a way they understood during labour and birth. And thinking about language again and how we use words, and some of you may have seen this particular infographic presented in different ways before. It's about changing the language from maybe what is the matter with you, which is a problem-based deficit model or approach to care, changing the language to what matters to you, what is important to you. And again, it's just a simple shift in language and in the way we use words, but that change in language can change it to a more capability, strength-based focus in that questioning, very much reflecting the Nursing and Midwifery Council new future midwife standards, that building capability in women. So that language is really, really important when we're thinking about personalised care. And we wanted to just drop in the Ockenden review, and particularly the second key interim recommendation, which is again was around listening to women and families and being sure that maternity services hear what women and families have to say. And the recommendations there are that this needs to be led at a senior level by the trust board, and also that the CQC visitors, when they come, they must look and be sure that this is happening, and it's not just something that's a box somewhere to be ticked, but it's actually having a meaningful impact on the care that's being provided. So again, it's that listening and that language which is coming across as being really important. So just before I hand you over to Ashleigh, I just wanted to think a little bit more again about why we think that the humanities are so important to the challenges that midwifery face. I've got a definition there of what the humanities mean. I'm not going to read it out for you. You can all read it, but it's particularly this idea about where we've been and help us to envisage where we're going. And I think that's something which we've heard a great deal about this morning already. I know when I think Marion was talking about the historical perspective on maternal mortality. I think all of that is really relevant for us to think about. And just a couple of images there as well to show, how midwifery practice has maybe changed a great deal from where we were, maybe with midwives working primarily in the community, to being maybe much more hospital focused, and working with many other different healthcare professionals as well. So leaving you with that, I'm going to hand you over to Ashleigh now, and I'm going to do the slides for Ashleigh.
Thank you, Suzanne. First of all, I'd like to start by saying how interesting I found this morning in the ways that the midwifery profession recognises emotions, process and relationships, they're all themes that I spend a great deal of time on as someone working in a humanities department. And what got me to my work with Suzanne was asking this question of how heritage and history can be brought to midwifery, not the past for the past's own sake, but rather for the future. And I think midwifery is at a really interesting point of transition for me to be coming in and doing this with Suzanne. So I've been having a look around at what's available to midwives at the moment in terms of recovering their own past. What I've put up on screen here is just a still frame from the Royal College of Midwives History of Midwifery video resource. I love these resources on the website. They offer a real in that we otherwise wouldn't have when it comes to communicating about the profession. But I was quite struck by how this slide here frames what we know about the 18th century or the 1700s, and that is about the switch to male-led midwifery. Now, while that's a useful thing to know in terms of the professionalization of midwifery and the development of education, my key question to any midwife is that all you need to know to use this within your own profession? And there are some fantastic women leaders in midwifery, more so than many other clinical and allied professions. So I want to expand out what is known about that heritage. And I do that by looking at publishing. If I could just have my next slide, please, Suzanne. What I want to explore today, just very briefly, through midwifery publishing of the past, not just the history of practice, is the lots of different models of midwifery that we recognise today and how they all have their own historical story. It's not a one size fits all, particularly when it comes to personalised care. And it's by bringing these to life that we can identify where your practices come from right now, where the practices of your educators came from, and how changing continuity will continue to impact the profession as it reaches out into a different future. Excuse me. So if I could just have my next slide, what I'd like to show you today is just a couple of examples of how midwives from the past talked about their own practice, discussed and reflected on what it was that they did. And I'm hoping you'll see some connections and maybe some contrasts to what you do today. So what I've got here is an extract from a case history by a man midwife called Edmund Chapman, who published his own casebook in 1735. Now, I won't read out the whole passage, but it is there on the screen for you to look at. And this is a description of what Chapman determines to be a large child born by natural pains, meaning he's not introducing C-section. About 2 hours of labour ensue before he's called in to intervene. And this passage really reflects on the mindset he uses to talk about his model of care. He talks very much about what he does, passes his hand into the womb. I should say some of the physiological manoeuvres have changed quite a bit. There are some that you would really wince at today. Chapman finds that there are 2 children in the pregnancy. We have no scans, so sometimes that's quite common that you'll find that quite late in the pregnancy or even during the delivery. He delivers what he calls a decayed child, so one that has suffered mortality in pregnancy. And he's discussing his own actions, and the way he does this is to employ what historians now call linear discourse. He states the facts of the birth, what happened. He gives very little context. There's nothing about the woman herself in this passage, other than he refers to her as a mother. He will sometimes give the employment of her husband, but no more than that. And he will focus on the physiology at all times. And he does this with all of his cases. And we might recognize this today as what we'd call a process-led birth. He's ticking the boxes of the education. He's following the guidelines he's been given in his own education. Have I done it right to do it safely? And there's nothing wrong with what Chapman does. If we look to the bottom of the passage there, he saves the woman's life by his actions, which is something that we would all call admirable today as we look to make sure that those rates of infant and maternal mortality are as low as possible and possibly non-existent. So I want to compare how Chapman talks about his practice to how another practitioner does so. Suzanne, can we show everyone Sarah Stone, please? Now, this case study for me is interesting, not least of all because it was written by a woman. We are so often told stories about how women's literacy, women's education, and women's rights have been so far behind those of their male peers. So whenever I find a medical female leader in the books of history, I am always determined to bring her out and give her a good showcase. And that's what I'm going to do with Sarah today. So Sarah was an experienced midwife practicing in Taunton, Bristol, and we believe London at about the same time that Chapman was practicing in London. And she was the first midwife, woman midwife that is, to publish her own case histories, which is quite a big deal when you've got no predecessors, no role or very few role models. So she's a bit of a pioneer in herself, and yet I very rarely meet midwives who know of her. If you did, well done for that. And what Sarah does in her own reflections on her practice, she uses case histories too, like Chapman, but her entire style is transformed. She uses what we call circular discourse. So that is to say that as a practitioner, she looks at the emotions of the woman at hand. She looks at their state of mind. She considers levels of pain. It's all in there. So if we look at this particular case, she tells us where she was sent for, where the woman lived, Wilton. She first, without going into any details on the physiology, I found her in small pain, but the child coming with the face foremost, and she was very low spirited. And I've highlighted these because they're important to Sarah. This is an early recognition. This is an early case of personalised care, something that we assume is a bit daunting at the moment because we don't have the models on wards to support it, but we know that's what we're aiming for. And yet here's Sarah 300 years ago saying, I'm going to consider this woman's needs. I've got that woman-centred care there. She gives advice on birthing and labour positions. She tells the woman to keep herself on the bed, lying on her back until she had strong pains. It is worth saying that Sarah never compelled a woman to a birthing position she was uncomfortable with, and she advises in her text that student midwives don't do that. She wants to support a woman in the way the woman wants to be supported. And that's not something we often recognise in medical history, but I think it's one of the reasons that it's really important that midwives are supported by humanities scholars to regain that history and to make sure that voices like Sarah's can be used when we're looking at personalised care and exploring what it means to support women. So in this case that Sarah presents, she says that there was no danger and she promises the patient that she'll do well. Now, Sarah would recognise the woman as a patient, much as its language we've changed today, and we tend not to use it in order to empower the women and birthing people in our care. To conclude the case, Sarah says that she was sent for again and at about 7, delivered the woman of a stout girl who was well. She had a little bit of bruising, Sarah goes on to say, but it's a good outcome. Now, Sarah published 43 different case studies, and most of them are all based around making sure she gets to know that woman who's trusting her, and she gets to know their needs, as well as ensuring safety. So these are just 2 different ways we can look at history through different sources and bring them to the discussion today.
Shall I move on?
You can do, Suzanne.
Okay, thank you. So this really is our last slide. I'm just looking at the time. I think we're doing well with the time. So just thinking about, new pathways for the future and how do we move these conversations on? And I think what Ashleigh and I have been talking about is that, language and metaphor is really important, and understanding that, and the humanities can really help us with that. And again, reflecting on what we were listening to this morning, the idea of assumptions and unconscious bias, often they come out in language, in the words that people use, and the way documents are written. And so getting that humanities perspective is really important in trying to understand why we're maybe hitting some of those barriers and we can't quite move things forward. The other idea that we're exploring with students, and hopefully in May and June we've got some seminars identified where we're inviting registered midwives along as well, is that we're hoping that by looking at case studies from the past and the language that's used there, that may help midwives to articulate some of the challenges and some of the cultural barriers that are present without necessarily thinking that it's about them and it's about now, but maybe thinking about what happened in the past and how that can inform what's going on into the future. So that's very much the next step of our project. And we're thinking as well, obviously, focusing on personalised care. We want to keep that care safe. That's really important. And we do think that our work will contribute to some of the the ideas, the policy statements within Better Births. So thank you very much for listening to us. It's a project in early stages, but we're very excited about it, and we think it will be we're hoping it will contribute to midwifery practice in the future. And we've just some contact details, and we have got a Twitter account as well if anybody's interested, Health Hums North, and that's us. So thank you very much.
Thank you very much. Very interesting. I'm just having a quick look at the chat. Oh, where'd it go? So there was one question from Helen at University Leicester. It was a statement, I suppose, more than a question. And it was just saying that in that comment from the medical staff about the ignorant midwife reference is a worry. Did you find that sort of situation in much of what you've read and looked at over the last times of the project?
We do, Diane, and it's a great one to pick out because one of the reasons I'm so interested in the 18th century rather than the 19th or the 17th is because some of that mythology stems from this period. And I think it's one that we hear echoes of in contemporary discussions of relationships between medical staff and midwives and bringing groups together. Now, what I would say about it is it did start from educational difference, and there is clearly a gendered colouring there from the past in that women were not permitted a university education. Really interestingly, most of the medical students who studied midwifery, it was introduced to the higher education curriculum in Edinburgh in 1756, will never have actually entered a live birth situation to secure their qualification. So whenever I see the word ignorance, my critical thinking head is always on. But I think it's part of the video I showed, that idea of medical takeover and male-led medical takeover comes from some of that educational difference. And one of the reasons that I bring Sarah Stone out so frequently, my students are completely used to me doing this, whether they're literature students or midwifery students, is because there are alternative histories that I think we need to get out there. Midwives can be really deflated and their ambitions compromised because of those long-term echoes. And I don't think we've yet dealt with how damaging that is in professional equalities. And I think it comes back to some of what Gloria and the others were saying this morning about trust. We assume that it will hamper trust in the profession, which needs to change, quite frankly. You know, even if we were relying on 18th century practice now, which I'm very pleased we're not for some of the things that have changed since, I think it's important that we find those stories of people who did do extraordinary things, particularly women, and that we bring those out into the discussion, because I think we're asking, huge groups of women in particular to change the culture of midwifery without giving them any of the benefits of empowerment that so many other clinical professions have been supported by. And it's why I'm so keen to work with Suzanne, and she might want to say something from the educationalist perspective on changing that narrative, because there isn't a room for ignorance when we're talking about safety. So why should there be one in personalised care? And I think we can make strides in how we support midwives to become that practitioner they want to be without facing some of these barriers.
Thank you. Suzanne, you're going to...
I mean, I think what I would add about the value of humanities and thinking about personalised care, I do think personalised care is quite a challenge, and we've heard a lot this morning about why that may be. There's a very real need to keep women safe and to improve outcomes for mums and babies and for the whole family. We also have the challenges of, working very differently now, and instead of having a universal approach to antenatal care, maybe, can we really personalize it so that some women are only seen 3 times and they send us in a telemetry of their Doppler that they've done themselves at home? I mean, all of these things may come to pass, but hidden within that is still this, as Ashleigh said, this I think it's a bit about hierarchies, and it applies the inequalities to the intersectionality between the inequalities that women face, that non-white women face, that women from different social groups face, and that midwives themselves don't feel equal to some other professional groups that they have to work with, so that they always start the conversation on a back foot. And it's really interesting to think about, when did that start? Did it start in the 17th century? And if we know, what can we learn from that about how we can move forward and really impact? I'm not always that keen on the word empower, but really enable midwives to provide the care that women need and deserve, really. Yeah.
Thank you. And you're absolutely perfect on time. It's 12 o'clock. Please, can I remind everybody to put their questions in the chat as we go through. But I thank again Helen for being the first one to start us off. So thank you again, Ashleigh. Thank you, Suzanne. And I hope you enjoy the rest of the day as well. So thank you.
Thank you.